so it's recording. Okay, so from this point forward, it's recording. And I have a little bit of a PowerPoint that I'll share with you. Okay, talking a little bit about the reasons for insomnia and so forth and so on. Okay, and after that, we're going to have plenty of time for Q&A. This is going to be about an hour long. Okay, and if you have any kind of insomnia problems and you want to ask some questions, I have to tell you right off the bat that I can't treat you over this kind of venue. So if you ask me, you know, gee, what can be done about this, I can give you generalized answers. But if somebody asks me, gee, what do you use and how much do you use and when do you use it, that's more of a, you know, a treatment type of question. And when you treat somebody, you have to already have, you know, examine them, read their history and so forth, because you're going to find out there's so many reasons for insomnia. Okay, and that's why on the Facebook pages that sometimes you see me posting on, I cut short at a point, because when you treat someone, you have to do your due diligence. Okay, and a lot of people, you know, lay people can throw stuff out, but it's usually not a good idea. Okay, so we're at that time. We're about 5 minutes after. I tell you what, I'm going to share my screen. Let me see where it is. Right here. Okay, and let's see if I can get this where it belongs. Okay, if anybody's on the chat on the bottom of the screen, if you can tell me if you see this or not. Okay, I'm hoping that you can all see that. Okay, yes, thank you so much. Alrighty, so I'm going to just go. Listen, this is something I wrote a couple years ago, okay, and I just updated it a bit, okay, and this is called Why Can't I Sleep? Insomnia, the Scourge of the 21st Century. And let me tell you, it is a scourge. So let me see if I can get this to actually work. There you go. Insomnia, let's just define it so we're using the same terminology. It has been thought of both as a symptom and as a sign, because it can be a symptom like a sore throat, or it can be a sign of another type of disease. Okay, so the term insomnia is used with a disorder with the following criteria. This is from the Journal of Clinical Sleep Medicine in 2007. Difficulty in falling asleep, staying asleep, or non-restorative sleep. Really important, non-restorative sleep. This difficulty is present despite adequate opportunity and circumstance to sleep. So true insomnia is when you've tried everything, you tried sleep hygiene and so forth, and nothing's working. And this impairment in sleep is associated with daytime impairment or distress. In other words, you're groggy, or it's been bad during the day, and it has to happen a few times a week for at least a month. Well, you know, everybody's got situational insomnia, like, you know, you're worried about your child or whatever, or, you know, you had a fight with your partner, or whatever it happens to be. Okay, that's situational, and if you had a bad night, well, you have a bad night. Okay, so it's an occasional thing, but when it becomes continuous, okay, and you're seeing the downstream effect of it, which means you're not just yourself during the daytime, or you're dragging all the time, or whatever phraseology you want to use, and that's what insomnia is about. So the fact is that it is, the total prevalence is like half the population, okay? So the biggest problem is insomnia is too much treated like a symptom, or just is symptomatically treated, rather than it being diagnosed in the proper manner. Remember that a diagnosis is the estimate of the root cause of a problem. For instance, if you have a sore throat, that's a symptom. If you have strep throat, you now know why you have the sore throat. And you've heard me wax philosophic over the years about it's got proper diagnosis must be made. In other words, you got to find out the root causes of the problem. More than that, you have to find out the root causes. You have to find out what those root causes did to the body, okay, and have to treat both ends of the stick, and sometimes in the middle too. Okay, the consequences of insomnia, and this is from different journals that I read. It's for women, insomnia is more prevalent with both the onset of menses and menopause, okay, with the hormonal changes. There's a lot of comorbid medical disorders, psychiatric disorders, and working nights or rotating shifts all represent a, one more time, just speak the English language, all represent significant risks for insomnia. Now, I can tell you, you already know that I was a nurse for many years, but what you may not know is I was a night nurse for many years, a lot of years, okay? And if you want something to screw up your brain, work at night all the time, okay? So remember that these other medical disorders can cause insomnia. Insomnia can cause these other medical disorders, which is kind of interesting. It's important to recognize that these factors don't independently cause insomnia, but some of them will precipitate insomnia, and some of them, the insomnia will precipitate them. So there's a lot of people who have insomnia who have a very large risk for things like hypoxemia, too little oxygen in the blood, difficulty breathing, acid reflux, pain conditions, neurodegenerative diseases. The fact is, if you don't sleep, you don't heal. Okay? There's a boatload of primary sleep disorders and circadian rhythm disorders that are comorbid, if you will, or happen with insomnia. It is important to understand whether you have sleep apnea, if you have essential sleep apnea, obstructive sleep apnea, because those are things you can do stuff about. Okay, but a lot of these things are used interchangeably. So insomnia and circadian rhythm disorder, it's kind of the same thing. A night shift disorder. I think that the psychiatrists kind of didn't make up diagnoses, just made up descriptive terms so they could, attach different letters and numbers to it. I don't know why, but they do. Okay, so there's some of the nasty sleep disorders that you always get is like restless leg syndrome. Sometimes periodic limb movements. I see a lot of my patients complain of that. Sleep-related breathing disorders, snoring, sleep apnea. This can be nasty. This will really bring down your oxygen, okay, and cause all kinds of damage over time, okay? So it's really important that the causes of insomnia, especially like this, are identified, okay? And there are a lot of psychiatric disorders that are associated with insomnia, and a lot of them, depression is the biggest, okay? And if anybody remembers, way back when they did a study on, depriving people of sleep, and what it did after about 3 weeks, as I remember, it may have been shorter than that, was to cause psychosis. My sainted Nana, my grandmother, okay, I use her wisdom all the time. Okay, she always said, if you poop and you sleep, all will be well. Okay, and that's true. But let's look at the causations of insomnia, shall we? First thing, let's look at the sleep-wake cycle. Don't get nuts looking at this, okay? I want to point out some things I hope you can see. I'm going to describe it and use my cursor at the same time because I don't know if you can see my cursor. Look at the eyeball and the moon. Okay, sleep-wake is initiated by light. When there's light, there's a bunch of glutamate that's pushed into this supracosmic nucleus, and this is the paraventricular nucleus, and eventually what ends up happening is it ends up in forebrain arousal, okay? When the light goes away, okay, there's less glutamate, and the pineal gland, which is pumping out melatonin anyway, becomes more primary and stimulates, again, the supracosmic nucleus, and you follow this thick red line. And when you follow this, and it's not important that you remember the brain portions, everything is GABA, 5-HT. 5-HT is serotonin. Okay, so you need melatonin to fall asleep and GABA and serotonin to stay asleep. That's the takeaway here. And it is initiated primarily by light. Okay, this is a point that you need to remember when we're talking about insomnia and why we're having problems in this part of the century, the early part of the 21st century, and they didn't have the same problem the early part of the 20th century. So light drives the sleep-wake cycle. Why do we have problems? Because we have video games, large screen TVs, computer screens, EMFs. We have a 24/7 world. When I was a kid, I know, a long time ago in a galaxy far, far away, that's why I have the bald head and gray beard. The only thing that was open on a Sunday was the church and the bakery, okay? And TV at the time, which were smaller and black and white and so forth, they just cut off. They just, said, good night, we'll see you tomorrow at about like midnight or 11 o'clock. So guess what? There was less light and less stimulation as the day went on. So your circadian rhythms were basically maintained, okay? With the advent of 24-hour convenience stores, 24-hour this, 24-hour that you can get anything at any time, okay? Your stimulation, whether it's light or electromagnetic fields, but mostly light, will affect your natural circadian rhythms. People, if you're going to ask questions, do it towards the end, okay? Because then I'll happily answer all the questions, okay? um, so too much light affects the natural circadian rhythm. And if you notice, the kids are, looking right at, they'll have their iPhone or whatever, and they're looking right at it. And it's that concentrated light right in their face. And this is what's setting them off. And guess what? Have you noticed that teenagers, okay, they can stay up to all kinds of time, but at 2:30, 3:30 in the morning, they just crash, okay, because that's when the adrenals give out. All right, and then in the morning, their cortisol is low, and then towards the afternoon, it's getting towards normal, and then it starts taking off at night. So instead of having a high cortisol in the morning and a low cortisol at night so you go to sleep, it's actually reversed, and I call that a vampire pattern, okay? So the only population that does not have insomnia are the Amish, because they don't use electricity, okay, and they basically work with the sun. And frankly, one of the ways of curing insomnia, just so you know, is not to become Amish. I wouldn't go that far, but to go camping. Okay, I've been a Boy Scout leader since God's been a Boy Scout. And I got to tell you something. When we go on our week-long camps or 2-week camps, those kids, they will bounce off the walls at the slightest thing. The first night, they're bing, 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 bing. By the second night, they're tired, and because we don't allow any electronics whatsoever. And by the second, third, fourth night, they've reestablished their circadian rhythms. They're getting great sleep. They get up. They're happy. It's amazing. Here are some of the root causes of insomnia. This is why insomnia is so difficult and needs usually professional intervention to figure out the whys before you figure out the how. Cortisol imbalance, melatonin imbalance, epinephrine or norepinephrine dopamine imbalance, serotonin imbalance, glycine, GABA, glutamate, phenylethylamine, histamine. Okay, all these different things can cause insomnia. These are some of the root causes. Okay, and there's some genetic predisposition, as you may imagine. And one of them is, of course, polymorphisms with COMT, catechol-methyltransferase. And I tried to make that into a joke last time by putting an O apostrophe methyltransferase, because I'm in an Irish neighborhood here. Nobody got the joke, nobody laughed, but I left it on there because I insist on making a joke. Okay, but polymorphisms here, okay, may yield the inability to break down excitatory neurotransmitters, therefore making you more excitable. And of course, the answer to that is why. Okay, why is that happening? Okay, it's not just a matter of the polymorphisms, it's the cofactors, coenzymes, and actually what's stimulating the release of catecholamines, which are things like epinephrine, adrenaline, norepinephrine, dopamine, phenylethylamine, and so forth. And there is the warrior gene. In case anybody doesn't know, that's a Klingon warrior. And that's the MAOA, okay, classically considered the warrior gene. Okay, and there are studies out there, one they did in Scandinavia, that showed that all the convicted murderers had the MAOA homozygous. Okay, of course they made the conclusion that anybody that has MAOA homozygous was going to be a criminal, which is nonsense, because they weren't studying the entire population. They studied a very skewed population, people who actually got caught and had very, let's face it, is nature and nurture. So remember always that genetics loads the gun, but environment pulls the trigger, right? Okay, so you need to have a little bit more than just the gene to have a problem. So these may cause, these polymorphisms here, or SNPs here, may cause upregulation of catecholamines, and you can't relax. Okay, but you can't treat the SNPs directly either, but you can counterbalance with things like GABA or other inhibitory neurotransmitters. And the hint is, in that sleep-wake cycle, you can give somebody GABA, and you can give somebody 5-HTP. Okay, and I realize some people can't take that. There are other things to do. Okay, but the general idea is to balance neurotransmitters, not to directly treat the genes, which has been one of my big soapboxes for the longest time. This is a study that was done by the Neuroscience Corporation in 2012. It's a really interesting study. Let me go over how to read it. On the left-hand side, you see E-N-E-5-HT. That's epinephrine, norepinephrine, serotonin, glycine, GABA, glutamate, phenylethylamine, histamine, cortisol, and melatonin. Okay? And the second column are the optimal numbers that you're looking for. These were done by urinary neurotransmitter testing. Okay? And here they had 4 subjects. They had a lot more subjects, but they published this 4 subjects that all had insomnia. Okay, so subject number 1 had very high epinephrine, adrenaline, very high norepinephrine, noradrenaline, reasonably normal serotonin, reasonably normal glycine. Okay, had high GABA. Where'd they go? High GABA. Okay, glutamate was on the higher side. Phenylethylamine was okay. Histamine was okay, a little on the high side. Cortisol was on the high side. So you can see that this person had very high adrenal output, and the body was trying to compensate, but just wasn't able to compensate well enough. In subject number 2, okay, you can see that the GABA was very low, where everything else was reasonably within normal limits, or just slightly high. Looking at the epinephrine, norepinephrine, okay, and the phenylethylamine was sky high. That will give you a very much racing mind, okay? So that's where the root cause is there, at least the neurotransmitter ones. Okay, subject number 3 had very low serotonin and very low melatonin. Okay, so the person had difficulty falling asleep, difficulty staying asleep. Okay, subject number 4 had high glycine and quite high glutamate. Glutamate is an excitatory neurotransmitter, and trust me, in high enough levels it will give you seizures, but it's sort of like throwing itching powder down your back. Okay, and it's interesting. So the point here, the takeaway here, is that even within just the neurotransmitter realm, a lot of different combinations of things will cause insomnia. And you could look at these patterns and say, it's adrenal. Great. Now, why is it? Then you have to ask, why are the adrenals upregulated? Oh, they don't have enough serotonin. Well, that makes sense because, if they don't have enough serotonin, which creates melatonin, okay, you're not going to have enough melatonin. Get that to a certain level, you won't be able to fall asleep. Okay? How do you diagnose insomnia? Okay, this is a really important thing. History, history, history. You know my favorite joke, people. In real estate, it's location, location, location. In medicine, it's history, history, history. So, if your healthcare provider listens to you, if you listen to your patient, they'll tell you what's wrong. It's one of the things I keep teaching other physicians, other healthcare providers, and I teach them the value of taking a history verbally, physically, rather than having them fill out forms and just hand them in. Okay, it's really vitally important that your healthcare provider discovers the root cause of the insomnia. Otherwise, forever, you're going to be treated with what I like to call Band-Aid treatments, and they have their own problems. For instance, sleep medications, Ambien, Lunesta, Zolpidem, and the like. These are sedative hypnotics. These are dangerous medicines. A sedative hypnotic, first of all, the sedate, you understand that, but the hypnotic portion, okay, these, if you read about them right out of the scientific literature, are not to be taken for more than 2 weeks. This is for transient, insomnia episodes. But how many people do you know that take them forever? Okay, and what's going on with this is that people are finding themselves at work, don't know how they got there, cooking entire meals. People are going to be falling down the stairs and so forth because they're under the influence of a hypnotic. Okay, it's not sleep. By the way, when you take Lunesta, Ambien, I don't care what the commercial looks like, you are not sleeping. That is very poor quality sleep. You have your eyes closed, but you're not sleeping. Okay, benzodiazepines like Valium, Ativan, Klonopin, and the like, they have constant problems like drowsiness, dizziness, loss of coordination, blurred vision, loss of sexual interest and ability, constipation. And remember that anybody who's been on benzodiazepines for a very long time, you've heard horror stories about being able to come off it. It's not as easy as it looks. It does some damage to the GABA-A receptor. Okay, I'm working with other professionals right now looking for a way to fix that. But it is another scourge because they're so freely prescribed. Okay, even melatonin can be a problem. Remember that melatonin is a hormone. Okay, it's pretty powerful. And for most people who take it, if you're taking small doses, it's usually not an issue, but it can cause daytime sleepiness, dizziness, headaches. There's been some long-term studies talking about cardiac difficulties with long-term use of melatonin. Plus, it's normally inappropriately dosed. You shouldn't need more than 1.5 to 3 milligrams of melatonin. Okay, more than 3 milligrams, you're not doing yourself any favors. Okay, and they sell it in 5 milligrams and 10 milligrams. Okay, plus if you wake up in the middle of the night at a certain time, taking more melatonin is kind of not the answer. Okay, so, and also there's a lot of side effects and interactions with other medications. So melatonin is not a benign thing to take. I do use it. I use it sparingly. Okay, I use it with kids at 1.5 milligrams, and I always make a joke that if you saw one of my posts when I was in Poland, okay, and I made a joke with a dad that he should be careful giving it because the kid's just going to go boom and fall asleep. Okay, and he thought that was funny, but within 5 minutes of giving him the melatonin, the child did fall asleep and rather nicely. Then I put a video that I found on YouTube that had a little girl in a bath, and I said, and she was falling asleep in the bath. And of course, she's being filmed, so there was a parent watching her. But I said, please, 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 give the melatonin after the bath, okay? Because you don't want people falling asleep like that. But you don't need more than 3 milligrams. If 3 milligrams is not working for you, then there's another problem. So, diagnosis, history, physical examination, because insomnia is a feature of numerous other diseases and pathologies. Laboratory assessments for the most common imbalances like diabetes, thyroid, hormones, immune problems, chronic infections. Either urinary neurotransmitter and saliva neurohormone assessments for adrenal function, or the organic acid test, and the Dutch hormone testing. Dutch will also give you the sex hormones, and it will also give you the adrenal hormones. Okay, and assessment of the GI tract for leaky gut syndrome and dysbiosis, which can cause all kinds of inflammation. And of course, a review of the epigenetics for the SNPs for possible biochemical pathway anomalies. And the reason you do that is because if you understand the pathways and you're looking at the polymorphisms, you're saying to yourself, gee, if that aldehyde pathway is kind of, wonky looking, and let me ask you how they handle alcohol. And if they don't handle alcohol very well, that's going to tell me that, and especially if they create sugar, that they have a yeast problem, okay, which could be the root cause of all of this. So how does one treat for insomnia? Okay, I like to always talk about Occam's razor, okay, and this is Brother William Occam from the 14th century. And I'm not even going to try and pronounce the Latin there, okay, but he says when you have two competing theories that make exactly the same predictions, the simpler one is the better. In other words, the simplest thing is usually the truth, okay? So, basics. And a lot of people don't pay attention to this, by the way. Good sleep hygiene. Perhaps avoid napping during the day, okay, because it can disturb your normal sleep pattern. Avoiding stimulants in the evening, okay, that's kind of a no-brainer. Okay, how did that get there? All right. Alcohol. Alcohol will put you to sleep, okay, but later on, it'll create arousal, okay? And that seems kind of backwards, but let me tell you why. When you drink alcohol, it stimulates the GABA-A receptor to release GABA, and you're going to fall asleep, okay? But as it metabolizes into an aldehyde, ethyl aldehyde, which is one carbon away from formaldehyde. So as it's, especially if you're drinking a fair amount, as it's metabolizing, and if your aldehyde pathway may be blocked up a bit, okay, you're going to get a higher level of aldehyde, and that's going to stimulate your brain, and you're going to wake up, okay, or you're going to have very poor quality sleep. Sleep hygiene, exercise can promote good sleep, but vigorous exercise should be early, relaxing should be later. Sometimes food, a large meal before sleeping is going to be disruptive, either because you have food allergies or it's just stimulating you. It's not a really good idea to have a lot of food before sleeping. You should expose yourself to adequate amounts of natural light, okay? The trick with using light is to use natural light, okay? And that can even be just, having, a lot of open windows, not, staying in a dark place all the time, okay, being outside. There's also the grounding, that's also important, okay? Establishing a regular relaxing one more time. Establish a regular, relaxing bedtime routine. Okay, so try not to get into these heavy arguments and just before sleep, and don't dwell on things. A lot of this stuff is recommendations, but they're easier said than done. Try and if anybody remembers the TV programs from the 50s, like Father Knows Best and that kind of stuff. They always came home. The father came home. They all had dinner. The kids did their homework, and they hung out with their friends, and everything was just heading towards sleepiness. It was just winding down. Kids got to bed early. The parents hung out together a little bit. We have too much going on right now that stimulates our brain, and that has to be held down. Your sleep environment should be pleasant and relaxing, but not too cold, not too hot. Actually, more on the colder side. Okay. You should associate your bed with sleep and sex. It's not a good idea to put your TV in your room, listening to the radio, reading. I tend to read to relax myself, but I can understand their point because you're stimulating your brain. But if you put a TV in there, it's the light and the electromagnetic fields. Okay, and there's I did a whole podcast on electromagnetic fields that you can get on my website that talked about how far away you should be charging your cell phone and so forth. There's a lot with electromagnetic fields these days, so don't ignore them. Okay, so how do you treat insomnia? Remember, finding the root cause. But if you're looking to reestablish neurotransmitter balance, we usually use targeted amino acid therapy, which is giving you the precursor to the particular the particular neurotransmitter. So, like I said, 5-hydroxytryptophan or tryptophan for serotonin and the like. You have to treat the underlying causes. You also have to find out what the underlying causes are. Okay, reestablishment of the cell wall integrity is usually very important. Okay, a lot of people use essential oils for energetic balancing, and essential oils do work very well. Okay, mitochondrial support. Most of us have mitochondrial dysfunction, and of course, assessment of the sleep hygiene, which is going to help. So anyway, when you're looking at somebody and trying to figure out what's wrong with them, you have to look at the person's condition as the supreme individual physiology that they are. This is why protocols don't work. Okay, protocols work for some people, but not for others. Mostly not for others, because everybody is a dynamic system with innumerable variables. So if you're trying to treat insomnia, you can't just pick up, Joe Schmo's insomnia book. Okay, aside from the obvious, which is sleep hygiene, that only works for a few people. And of course, the testimonials are for those people it worked for. Okay, and you have to, you have to not treat by protocol. You have to, if insomnia is a real problem, you need to work with a practitioner. If you do the sleep hygiene stuff and the simple stuff, it's not working, you have to work with a practitioner that is willing to go the extra mile to figure out why you're having the problem. Because the reason we have so much insomnia is because people are treating by symptom only, hence all the prescriptions for benzos and Lunesta and stuff like that. They're treating by a protocol. They're just, okay, here's my sleep protocol, there you go. Okay, or they're treating by symptom only, and people are continuing to suffer because of lack of due diligence. And you know how I feel about that, okay? You know that in our office, Sean Bean and I, we're experts to discover the root causes of insomnia and other illnesses, okay? Because we look at the root causes, we look at the downstream effects, we look at the genetic contribution, and we try and treat in as much of a holistic manner as we can, okay? Anybody who wants to contact us, I offer complimentary 15-minute get acquainted sessions, and all you have to do is go to my website and sign up for that. The reason I do that is because, and I talk to people all around the world, is that once we've had a little chat, I can let you know if I can help you. You can be comfortable whether you're comfortable with my presence, and it always makes things a whole lot more fun to work with and a whole lot more better. A whole lot more better, is that English? Oh, I don't. Anyway, Sean, this is his number, and that's how you get in touch with him. And if you're looking for a copy of this particular talk, it's on my YouTube channel already, but I'm going to try and get this one exactly onto the YouTube channel fairly quickly. So that is kind of it. So I'm going to go back to hi everybody. Okay, so if you look and start typing in questions, with the amount of people we have, it would be let's try typing in questions. I guess I could unmute everybody, but I don't know how that's going to it goes to a free for all. Anyway, the first question I have here is, what if you can't take 5-HTP? I'm on pain medicine medications, so they talk about. Okay, what if you can't take 5-HTP? I'm on pain medication, so they talk about the risk of serotonin syndrome, and my serotonin is checked and it's fine. I have low dopamine. Okay, if you can't take 5-HTP because somebody told you that you're going to have serotonin syndrome, they don't know what they're talking about. Okay, and let me explain. There are 2 studies out there right now that have 5-HTP and serotonin syndrome together. One of them, the first one, says that you can't get serotonin syndrome by taking 5-HTP with or without an SSRI. The second one said, oh yes, you can get serotonin syndrome, but the study was done on 1 dog. Okay, and if I find these people, I'm going to get them. 1 dog. Okay, and I don't know what they did to this poor dog, but they gave it serotonin syndrome one way or another. Okay, the reason you cannot get serotonin syndrome by taking an amino acid is as follows. Number 1, when you give the body the amino acid, it's going to produce the neurotransmitter. But once it has enough of the neurotransmitter in the storage areas, the manufacturer, if you will, stops manufacturing, and you have a bunch of 5-HTP running around, which will either come out in your urine or get turned into glucose by a process called gluconeogenesis. So nothing bad is happening, okay? And you can't make it happen. The reason that you can get serotonin syndrome by overdosing on SSRIs is because the serotonin selective reuptake inhibitor is working with the receptors within the synapse. So you can block those up pretty good and raise the amount of serotonin that's supposed to be recirculated and get serotonin syndrome. It's very rare, but that's the only way you can do it. If you're doing it from the manufacturer and if you're just producing serotonin, it's not going to happen. Okay, once you have enough, the body signals the stopping of or the slowing down of the production. Okay, and if you have low dopamine and you're looking for, you have to remember that if you pop up your serotonin, you're going to push the dopamine down even further. On Bacopa, your thoughts on Bacopa to balance neurotransmitters? I'm going to be honest with you, I'm not very learned in a lot of the herbs. So that's probably not, I probably can't give you a good answer on that one. Let's see. A lot of people use, for essential oils for nighttime waking, a lot of people use lavender. Okay, a lot of people use frankincense because it's an anti-inflammatory. But I will tell you that the better look, when you can look up a whole mess of essential oils that are good for sleep. But here's what you have to be careful of. You need therapeutic grade essential oils. And I know that Young Living and doTERRA make very, very good products. Okay, I'm sure there are other companies, but they have to be therapeutic grade. There's also something that you might want to look into when it concerns essential oils called the rainbow technique. Okay, I'm sorry, the raindrop technique. Okay, where they have a set of oils that someone uses down your spine in a certain pattern, okay, and it energetically goes throughout the whole body and balances the entire body. And I've seen that work very, very well. A little smelly, but it works really, really good. Personally, I use lavender, and you can put it out into the air. You can put it on your body. If I'm using frankincense, I use it on the bottom of the feet. Frankincense is a great anti-inflammatory since inflammation is the reason that a lot of people have insomnia, okay? Next question was, do I use melatonin only on an occasional basis? If not, how long do you use it for? It depends, like everything else in the world, right? If I use it on somebody who's got insomnia that I know, first off, lots of times I may not know the exact root cause when I start treating something. So I'm going to treat empirically by what I've seen, what my history says, and so forth. So I will trial a little bit of melatonin. In other words, I'll try it, and if it really helps, I'll continue to use it while I'm getting either the studies back or seeing how high their serotonin is. If I'm doing it empirically, I'm going to be giving serotonin precursors like either tryptophan or 5-hydroxytryptophan. Let that build up for a while before I withdraw the melatonin, okay, because that should create more melatonin just because that's what it does in the pathway. Okay, it's a little bit of legerdemain, or you can measure it. Okay, you can measure melatonin, I believe, and you can measure serotonin, obviously. Okay, and you can measure the downstream effect like the 5-HIA and see exactly where this, how much serotonin is being broken down. It can get a little more complex, but I don't usually use it for more than a couple of weeks. If you need it longer than that, then something's usually wrong, that I'm either missing or I need to investigate further. Okay, how do you know when to use, this is a really good question. How do you know when to use the regular GABA, where the regular GABA should be used versus the phenylated form? Will liposomal GABA cross the blood-brain barrier? The difficulty with GABA, taking it externally, is the blood-brain barrier. Things like pharma GABA or the regular GABAs that are out there don't cross it. Okay, but it does help some people, and the reason is because they have a leaky blood-brain barrier. Okay, that's kind of the one of the ways you can diagnose leaky blood-brain barrier is if they're taking a regular GABA and it's calming them down. That's how it's getting in there. Okay, other than that, you need either a phenylated or a liposomal form. Okay, phenylated is commonly known as a phenibut or phenibut. Okay, and people will argue with me about this, and they have argued with me, and they lose the arguments all the time. Okay, there's two forms. There's a 4-amino-3-phenylbutyric acid, okay, which usually comes out of Eastern Europe, or it is Biotics makes it as phenotropic, and neuroscience used to make it as cabanase. And there's another form, I think it's beta-phenyl gamma aminobutyric. I can't call it up in a second, but that's the more common phenibut that you see. The second one that I mentioned that was more common is the one that seems to have a lot of side effects from it, and a lot of people have trouble withdrawing from it and so forth. So in a lot of countries, this has been banned, but the 4-amino-3-phenylbutyric has never had that problem. Okay, some people say it's a taxonomy. They tell me, oh, it's just the same thing. It's not. I've been using it for decades. It's not. It works really, really well, and there has been no problems with it whatsoever. So if you're going to use a phenylated form, okay, in the United States, it would be either something called phenotropic, which is made by Biotics, or cabanase, which is made by the Neuroscience Corporation, if they are still making it. In Europe, you still can get those two products, but you would see that stuff coming out of Eastern Europe. Okay, that's where they did all the studies. And most of those studies are in Russian. Will liposomal GABA cross the blood-brain barrier? Yes. Okay, the blood-brain barrier is a fatty barrier. Okay, and it will get through. And there are, I think there's only one company that makes, I may be wrong, makes a liposomal GABA, and that would be Quicksilver Scientific. And they have a GABA and L-theanine product that works incredibly well. Okay, L-theanine has a tendency to bring down glutamate. So a lot of times if you're having excitation, glutamate is an issue. And I've seen this particular product work in less than 5 minutes. Having somebody sitting there in front of me, and then me give them 4 sprays, and 5 minutes later they're just relaxing. So it really can get through the blood-brain barrier. The next one is, what's the timing on taking 5-HTP? There's no official timing, but I generally give it in the evening because I want the person to start getting some more some more serotonin while they're asleep. Okay. Generally, that's when I do it in the evening. It could be just before bed. Be a little careful with 5-HTP. Some people don't handle it very well. Sometimes it irritates the stomach lining. Okay, and if you take it with food, you're just going to slow down its absorption. Okay, which is fine. Okay, no problem with that. Some people have it in a lozenge, which is a little easier. Okay, and there's only one company that makes it in a liposomal form, and that's Physica Energetica, which is Physica Energetics in Canada. And I like liposomal because it gets in. Okay. Question. Okay, it says, is the Dutch test the best testing to figure out the root cause of insomnia? No, not the best, not the only. Okay, this is where your history comes in. If you think it's primarily a hormonal problem, then the Dutch test is the best way to assess the hormones. Okay, the sex hormones, plus you can put the adrenal hormones in there. If you think it's a predominantly neurotransmitter, and again, you're going to find this in your history, then, basic neurotransmitter test is a good idea. Or you can do the organic acid test, which will tell you a whole mess of things. Let me tell you something a little bit about the organic acid test, okay? The organic acid test is really very useful because it will show you the results of what's going on in the pathways. If you understand how to read it, you can tell what is going on in practically most of the pathways that you're concerned about, okay, to including neurotransmitters. There are metabolites, but you have to know how to read it, okay? But you can tell not only what's going on in the gut, you can tell what's going on in the whole Krebs cycle and the whole, the whole creation of ATP and many, 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 many other things. Okay, so people are very conscious of reading genetics. The genetics only tell you probabilities. They don't tell you what's going on. They tell you what might happen. Okay, so if you look at a pathway and it looks really wonky, all that's saying is that that pathway may have a problem under an oxidative stress load, but you don't know that that's actually happening. Okay, you either get that by history or you get that by testing, and the best test for that is the organic acid test. So if you were if you had insomnia and you wanted to get the biggest bang for the buck, so to speak, okay, I would think about the organic acid testing. I happen to like the one from Great Plains Laboratory. That's just me. There's plenty of others out there. Okay, and I would probably do the Dutch test. And I would do the Dutch test complete because you'd have a big picture of the hormonal portion of what's going on with your body, which can easily cause insomnia, and practically every other pathway. You got to have a practitioner knows how to read it. Okay, let me tell you something. It is not a matter of just reading what you're reading and then looking at what the company says. This is not easy. Okay, it is complex. You need to know the biochemistry. If anybody knows Elizabeth Lambert, who's now used to be my student, used to be I mentored her for, and then she's way exceeded me, and I feel like she's like Darth Vader. I once was the student, now I'm the master, and she's the master, all right. Okay, that woman is one brilliant individual. Okay, and she's teaching all around the world reading the organic acid testing. And let me tell you something, it is complex, but once you understand it, you get such incredible information, okay, that it shortens the distance between A and B and healing somebody. Okay, so those are the testing that I would think of. How do the medications codeine and DM affect sleep? Well, codeine and DM, which is dextromethorphan, which is codeine's fourth cousin, okay, affects sleep by making you drowsy, okay, but you need a heck of a lot of dextromethorphan. That's why some people are addicted to cough syrups, okay. Codeine, again, is a sedative, and it's used to calm coughs usually, okay. 5-HTP helped me, but I took it for a year. I've stopped, but now I find help with I think you mean to say CBD oil, and Chinese skullcap for virus infections. What you're doing here is, I'm glad that you were taking the 5-HTP, but if you took it for a year and it didn't resolve the problem, what you're doing now is using CBD, which is cannabidiol. Okay, for those who don't know, the marijuana plant has two separate main ingredients: THC, which is tetrahydrocannabinol, which is the psychoactive substance, is what makes you high, and it has cannabidiol, which is a non-psychoactive substance, which has been touted to cure enormous amounts of diseases. As a matter of fact, in its pure form, it's said to be able to cure cancer. Okay, I'm not going to get into that discussion. Okay, but it's being made more and more available in higher and higher concentrations. So, some people use it as a pretty good sedating agent. It works out fairly well. Okay, but what it's treating is the inflammation. You still haven't gotten the answer. Okay, and if the Chinese skullcap is helping, then you probably have a viral load. Remember that most people don't have one problem. Okay, most people have several problems. So when you have a microbial issue, it's probably viral. It can be fungal. It can be mold. It can be any kind of bacteria. It can be parasites. It can be a whole lot of things. Okay, so if you're finding that you have to use different things to manage your insomnia, I can tell you right now that the root cause has not been found. Okay, and I suggest seriously that you take a deep look into that. Someone here just is mentioning that she mixes frankincense with coconut oil on the bottom of her feet. Okay, for whole body inflammation, absolutely fine. She uses 50 milligrams of niacin. And niacin, which is B3, is wonderful, okay, because it's used in almost every bodily process. I will advise you to be careful about niacin not taking more than 500 milligrams a day. If you do, which is, I mean, it's not going to hurt you, but it tends to undermethylate people. Okay, we have overmethylation. You have to give people niacin. Well, you can do the opposite. Okay, how do you heal a blood-brain barrier? I'm going to give you all my secrets right now. Right, it's the same way you heal a gut. Okay, healing a leaky gut, healing a leaky blood-brain barrier, same exact thing. Okay, you need to provide the body with phospholipids. You need to provide the body, well, for the gut, you need to provide something for a mucus layer and to help the cells heal. Okay, but mostly it's phospholipids and really getting at the cause of the inflammation. We're getting at the cause of the bacterial endotoxins or exotoxins that have been assaulting it. Okay, that's and it's real important that you heal the blood-brain barrier because nasty things can happen. If stressed, my sleep cycle goes haywire. Doesn't take much. Could be due to adrenal fatigue. That's true, and that's yeah. So remember, root cause, downstream effect. You got to treat both. Okay, you have to identify both, and you have to treat both. Okay, so yes, it could be adrenal fatigue, but then what do you do about it? Okay, if you're getting a little bit of stress and your sleep cycle goes haywire, that just means that your homeostasis that is very tenuous. Okay, so your homeostasis just balanced, and it doesn't take much to knock it off balance. Okay, that's an indicator that you need some. If you're good at this yourself, you can go through the whole diagnostic process. If not, this is the kind of thing that if you've been dealing with it for a while. I'm not saying that everybody needs to see a practitioner all the time. The criteria would be if I've done my work with the sleep cycle and the things that are really obvious, and I'm just not getting anywhere, or something like this where if I'm stressed, my sleep cycle goes crazy, and this has been becoming a problem. Well, guess what? Okay, it is a problem. And if you're at that point where you're chasing your tail, or you're reading this article or that article, or listening to some people on Facebook and trying one thing after another, you have to say to yourself, stop. I got to figure out what's wrong. And remember that there's a great saying out there that a doctor who treats himself has got a fool for a patient. And I've been a fool many times. Okay, but that goes for patients too. All right. Why would niacin cause severe swelling in your ears? Niacin causes a flush. Sometimes it's just in the ears. There's no more questions? Come on. You guys have to have all kinds of questions. Do you recommend inositol for insomnia? It depends on what your needs are. Okay, it's difficult to say one thing for insomnia. Okay, that's why I get a little upset when I'm on Facebook and I'm like, sometimes you see people answering a lot of different questions, giving people ideas. Okay, that's great, but you can try it. Trouble falling asleep and getting restful sleep is your issue with almost no REM sleep. Okay, so here's the thing. If you remember the sleep-wake cycle, and if you were going to do this empirically, in other words, you were going to try something before you found out what the actual root causes are. Okay, you would think about melatonin, because that's what puts you to sleep, and then you would think about raising serotonin and GABA. Okay, and you heard me talk about the products for that. Your REM sleep is, what this means is you're having no REM sleep, is that once you get past that very deep sleep, if this is where wakefulness is, you're supposed to do these little 90-minute cycles until morning. You probably have enough excitation that once you get past the deep sleep, okay, when you finally get there, you're popping up every 90 minutes, but it's above the wakefulness area. Okay, so there's a base excitation going on, okay, that you have to find out the reason for. So PC helps the BBB, and I'm glad I'm not an English, so it means BPC. I'm using PC and SAMI to heal myself from MAT 1A. I don't mean to be offensive, but you don't heal MAT1A. Okay, you can work on genetic expression. Okay, but you can't heal a gene. Your genes are your genes. Okay, but your message here is that if you're using the PC phosphatidylcholine and SAMe to heal whatever the effect of the polymorphism at the MAT1A, okay, you're also helping any other cells that require building up. Okay, now you've got 30 trillion cells, so I'm willing to bet that it's helping a bunch of other things also. Here's a piece of advice for people using, phosphatidylcholine or any other phospholipid. You can easily get it in the form of a lecithin, sunflower lecithin, soy lecithin, egg lecithin. That's a mixture of phosphatidylcholine, phosphatidylethynolamine, and phosphatidylinositol, which is the whole pathway how you get to phosphatidylcholine. Remember always that a lot of people have gut problems. So you put something in the gut and it's got to go to the bloodstream. Then when it's in the bloodstream, it's got to get into the cells. So sometimes you want to take things in a form that at least gets it into the bloodstream quickly or better, or gets it directly into the cells. How do you get it directly into the cells? The only way you can do that is with a liposomal form. Liposomes are like little missiles. Okay, now they're half water, half fat. But whatever you can pack into a liposome, we're going to get directly into the cells. So a lot of the liposomal products, you've heard of liposomal vitamin C, liposomal glutathione, gets directly into the cells. Remember that everything that goes on in the body happens within the confines of a cell. Okay, it's not, your methylation is not over there, glucuronidation is not over there, bioptin is not over there. It all happens in the cell. So the cell has to work. And one of the integral parts of that is getting the cell wall functional, because the cell wall is not just a cell wall. It's not just a wall, like a wall around a castle. It's, that's where the proteins go through. That's where the active transport mechanisms are. Okay, well, it's the lifeblood, sorry, stupid analogy, okay, of your cell. Okay, and remember, if your cells don't work, nothing works. Because you put the cells together, you got tissues. You put tissues together, you got organs. You got organs together, you got a body. It's the cell. So when you're using phosphatidylcholine and you're taking it by mouth, if you're having difficulty with digestion, okay, you're having leaky gut syndrome, you're having difficulty in fat digestion, you're not getting all that phosphatidylcholine because it is a fat. So think about that. You might want to use some of the transdermal patches that are out there that will get phospholipids directly in through your skin, or consider a liposomal product. My cortisol is in fact flip-flop, but that's only testing I've done. Well, if it was flip-flop, that's that vampire pattern. Okay, so there's lots of things you can do with that. There are products that can bring down cortisol, other products that can bring up cortisol, and you can use that to help reset the circadian rhythms, or you can do some natural things like exposing yourself to natural light, doing all the sleep hygiene stuff that helps get that, reset, and you still have to look at root causes, okay, because if you don't, it's going to stay like that. But a lot of times, if you do the sleep hygiene things, you'll reset your circadian rhythm. It may take a bit of time, but it'll happen, okay? Unless you want to go on a two-big camping trip, like good camping, just without any electricity or anything. Sometimes the showers are okay. Is increasing magnesium a good idea for better sleep? Often it is. Often it is. Often that's the only thing you need, okay? What dosage of phosphatidylserine do you recommend, and again, for how long? As I said before, I'm not going to give you dosages, okay, because that's treating you. Phosphatidylserine, I will tell you about for the moment. Okay, phosphatidylserine is a different phospholipid, okay, and what it does is reset the cortisol receptors in the hypothalamus and the pituitary. So when you have a fight or flight reaction, okay, what happens is you get a stimulation, okay, and that sets off the adrenals, right? The hypothalamus is stimulated. It sends a signal to the pituitary gland that releases ACTH, adrenocorticotropic hormone, that tells the adrenal gland to release epinephrine, norepinephrine, cortisol, and DHEA. Okay. Now, what happens there is that you get this fight or flight reaction. Think of the Incredible Hulk. Okay, this is perfect. Remember with the Incredible Hulk? Okay, Bill Bixby, the original one, not the new one, the original one. Okay, so he would go, he would go from town to town. He would go into a bar. Why he goes into a bar all the time, I don't know. But they start messing with him, right? And he gets real mad. And then he looks at them and says, "You wouldn't like me when I'm mad," right? With the eyes. And then all of a sudden, Lou Ferrigno. Okay, now that's the stimulation of the hypothalamus. the stimulation of the pituitary, and then the Hulk. That's the fight or flight reaction. And the Hulk goes crazy, does his thing. What happens at the end of the episode? He kind of does this, and he turns back into Bill Bixby. That's the cortisol going up to the receptors on the hypothalamus and pituitary and turning off the reaction. Okay? Now, our bodies, this is a BC body in AD time. We've not changed much since we've been cave people. Okay? And I will not sing the troglodyte song. I've been known to do that. Okay? So we are adapted to do a fight or flight reaction once every 6 weeks. Not 4, 5, 6, 7 times a day. That's how we're burning out our adrenals. Because the more stimulation you do of those cortisol receptors, they become desensitized and you can't turn it off. So the adrenals like, phosphatidylserine will turn off or reset, if you will, those receptors. That's why you see it in products like Serophos or ComPRT and so forth. Has slow MAO affect sleep. MAO affects sleep slow, faster, and different. Okay, because you can't break down the catecholamines. You can't break down. The indicator of a slow MAO is that it's not working as fast as it should. Okay, and monoamine oxidase breaks down epinephrine, norepinephrine, dopamine, and so forth. Okay, when that happens, if it's expressing, you're going to get a backup. Okay, it's sort of like a bathtub that has a drain that's about a quarter of the width. Okay, as long as it's just a little bit of water going through, it's no big deal. But as soon as you start dumping the water in, it's going to overflow. Okay, so the answer is you can't make the MAOA go faster. Well, you can by giving cofactors and so forth and so on. But theoretically, you can't make the genetic polymorphism change, so you change circumstances that causes it to express. So why is there an upregulation of epinephrine, norepinephrine, that kind of stuff? Okay, why, do I have enough cofactors and coenzymes to run the reaction pathway? And remember that MAO is around a bunch of places. Okay, so, and I know that Ben Lynch has got Dirty Genes out, which I, absolutely adore that book, because what it really does, if you think about it, okay, is it identifies, it gives you a way of looking at your genetic profile without being so ostentatious and letting you realize that he gives you a method of engaging in foundational treatment, okay, which is how you fix all this. The reason that people like me and Sean and Elizabeth and so forth have been really successful is because we tend to look at the foundation of the body and start treating that, and that's when people start getting better, okay? Okay, we're just about towards the end here. So any tips on nocturia? Well, that's a lot of urination, I guess, at nighttime. You have high, all right, anytime you're urinating a lot at night, simple things like, not drinking as much and so forth, but if it becomes a problem, you have to be checked for diabetes, okay? And there are other conditions that will cause you to have to urinate an awful lot, maybe medications you're taking and so forth. But diabetes would be my first thought, okay? When you see somebody with treatment-resistant insomnia, over 100 products and even a few medications on the side, in fact, the John has said never worked at all, what root cause do you immediately think of? Great question, okay? The first thing I think of is when I see this whole, and believe me, I'm never the first doctor anybody sees, okay? On the 10th, on the 15th, and the highest on the 175th. Okay, so I get to look at all the stuff people were taking. So I sit back and I look and I think, and I'm like, all right, they're shooting at the wrong target. Okay, so what root cause do I think? Well, it depends on what they've treated. Okay, so if you've taken 100 products that will all geared to neurotransmitters and stuff like that, that's fine. If you took products that did different things, I could rule that out of my head. Okay, but then what am I looking at? I'm usually looking at Lyme disease. I'm usually looking at other kinds of microbial problems. I'm looking at parasitic problems. I had one patient who was so badly filled with parasites that she didn't sleep. She looked anorexic and had chronic insomnia. And she was referred from a naturopath for me to do a consultation. And she said that she had to use enemas 3 times a day just to go. And I guess nobody asked what comes out. She says worms. you know, and you can see that. And I was like, let's send you to a parasitologist, okay, because the herbal stuff wasn't working. Well, 3 days into that, she started sleeping, okay, and it was a little rough from that point forward, but guess what? So a lot of infections, mold illnesses, and this is Abby telling me here, which is good. Well, mold illnesses, co-infections. I know Armin Schwartzbach from Armin Labs in Germany, and he and I had a conversation one day, and he agreed that Lyme is nasty, but parasites are worse. And the reason parasites are worse is because they're really hard to diagnose. You often have to treat them empirically, okay, like you suspected, and they are ubiquitous throughout the world, okay? Of course, one hint for parasites, and everybody laughs at me, but it actually works, is does it happen cyclically on a lunar cycle? So you get worse around the full moon, and some people get worse around the new moon. And one of the worst kids I've ever seen in my life, who looked like he was possessed, would exacerbate and start hurting himself and so forth at the full moon, new moon, at the quarters. Okay, don't ask me why it affects parasites like that. But if you have werewolf syndrome, you know, and everybody's been laughing at you, okay, think parasites. If you've tried everything else and you checked for everything else, okay, think parasites. Okay, if you wanted to learn a little bit more about parasites, on my YouTube channel, I have a whole video on parasites, okay? Mycotoxins will make all this worse, okay? If you, what are the hints about mycotoxins in history? Just so you know, if you're in your house and you go on holiday or you go on vacation and you get better and you come back and you get worse, okay? Or you go to, if it happens to be your work or whatever it happens to be, if you go to a place and you get worse and you come out, you're going elsewhere, you know, for a couple of days and you get better clinically, even if it's slight, okay, think about mold, okay? If somebody's been checked for parasites through every test imaginable, if you're satisfied you don't have it, you don't have it, okay? But if you're exacerbating at the full moons, you have to at least consider it, all right? But certain Lyme will do that too, all right? But I see it more in parasites, okay? Guys, it's about 5 after 6, okay? This was really wonderful. I hope everybody had a good time. I hope I didn't talk too fast. I hope that my Brooklyn accent didn't come out too much. Okay, and I really appreciate all the participation. I wanted just to have a venue where people could. Thank you very much, Carolyn. You know, that everybody could just ask about insomnia, and I think I'm going to use this kind of format for future issues. So if everybody sees, you know how to get in touch with me on Facebook and stuff like that. If you'd be so kind, if you have ideas of what you would like, you know, to talk about, okay, I'd be happy to talk about it. And again, just always remember, always, 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 you know, if nobody's told you they love you today, don't forget Dr. Jess does. You guys have a good day. Take care, all right? Bye-bye.